When was the last time you talked to a doctor about your sexual health? Today, we're lucky to have Dr. Justin Dubin, who's not just a colleague, but a friend. He's a board-certified urologist and andrologist. He trained at University of Miami, then went to Northwestern for his fellowship, and now is back in Miami running Men's Sexual Health Center at Baptist.
DocPod presents Health with Dr. Hal.
How are you, Justin?
I'm doing good, Hal. Thanks for having me. I'm excited to come on and finally do this. I've been enjoying your episode so far. So this is cool to gather another South Florida friend together here and chat.
No, that's awesome. First of all, I'm super grateful to Dr. Amy Perlman for even introducing us. It's been awesome having another referral partner down here, especially when we get out of our lane. So I appreciate you taking on, some of our patients that are a little bit more difficult. I did want to ask you, I know it's still, we still have 3 more days till Men's Health Month is over. What's one thing specific that you would like guys to know or do before the month ends?
So I think the important thing, there's 2 things. One, I think it's important that guys understand that most of us are not going to the doctor in general. Less than 50% of men are going to see a doctor on an annual basis. And the ones that are going are probably just going to like an urgent care or an ED or something like that to get some antibiotics or whatever. They cut their finger. And what we've realized is that this has become a difficult hurdle for many men to overcome. So I think, we've been trying to make it easier. We're trying to, we've changed the literature. We've looked at the literature, right? We've removed things like a rectal exam from having to be done for men who were scared to come in to get, screened for prostate cancer. You no longer need to get a rectal exam, or we called the urologist handshake, no more.
You should always check the size of the finger of the urologist when you walk in, right? That was the joke back in the day.
Well, the joke I use is, I like you, but I really like you. So I'm going to give you 2 fingers because I need a second opinion. So that's no longer the case anymore. So you can come in, get a PSA. Don't worry about, that uncomfortable exam. And, it's not just about getting screened for prostate cancer. One thing that we're going to see and talk about today is that your sexual health is your health. It's a window into your overall health and wellness. And oftentimes, if something's going wrong with your erections, something's off with your testosterone, it's often a sign of something else going on, or it's a warning sign of something coming down the pipeline with regards to your health. By actually, what I like to say is, by men, we think with our penises, we need to start thinking about our penises and how it impacts our lives, how it impacts our health, so that we can come and see a doctor and learn more about our penises and not just think about them all day.
Justin, I'm going to tell you a secret. I was actually a fan of you since before I met you, because back in 2022, you actually published a groundbreaking study. It was looking at the direct-to-care models that are out there. And what you found was eye-opening. And that's actually part of the reason why I went into men's health, to sort of help clean up the industry. Can you talk a little bit about that, what you found, what the big takeaways were from that study?
Yeah. So, when I was in 2022, 2021, so I did my residency at Miami, and then I did 21 to 22, I was at Northwestern in Chicago. And even in Chicago, starting in Miami, we started seeing this real uptick in our clinics of a lot of young men coming to our clinics for fertility evaluation who did not know that taking testosterone caused infertility. We're seeing a lot of guys who were on TRT, had gone either to these brick and mortar, to these telemedicine places, that didn't really understand what was going on, and basically were infertile because they were given testosterone when it was not indicated. And so we saw it in Miami. We saw it again, even in Chicago, a place I was surprised because, there's a different, now here that there's a different aesthetic here. There's a different group of people. People are looking for different things. It's a different population than that.
Remember, I actually trained in Chicago myself, a couple of blocks from you at Advocate Masonic, but I think we were off by about 5 years. I was there 5 years earlier.
I think it's the best summer city in the country.
It is. The 2 weeks of summer in Chicago are incredible.
Yeah, man, I gotta go back though. I was supposed to go Memorial Day week and I couldn't make it. But anyway, So we saw that also in Chicago, a lot of men coming in, young men who were trying for fertility for a year, 2 years on testosterone, were never informed that taking this medication can cause infertility. Why does it cause infertility? Well, when you take exogenous testosterone in any form, exogenous meaning testosterone that you're putting inside your body through injections, gels, you name it,
Thank you for
pellets.
helping to slow kids with that.
Yeah. What happens is your brain gets the signal, I'm making enough testosterone. It stops the signal, which is LH, luteinizing hormone, the hormone your brain makes, tells your testicles to make testosterone, and FSH, follicle stimulating hormone, the hormone your brain makes, tells your testicles to make sperm. Well, those are not needed, but when your brain gets the signal, I'm making enough testosterone, because there's a negative feedback that your testicles give to your brain. They're always communicating. And so when that signal is shut off, your testicles stop functioning, they atrophy, they stop making testosterone, and they actually stop making sperm. So about, even 4 months of taking TRT, about 60% of guys have no sperm in their ejaculate. And of course, our listeners are going to go, well, why aren't we using this as male contraceptive? Well, the data originally didn't guarantee for everyone. And I'm sure, you see online, you're like, well, I've been on testosterone for 20 years. I have 3 kids. Sorry, that's actually, most people are not like that. You are the exception to the rule. Now, there's always going to be people who aren't impacted by certain things, but the general majority of people, are going to have their sperm either significantly decline or not have sperm. In fact, now there's newer studies and new work with adding pregnenolone to testosterone, where we're going to have male contraceptives coming down the pipeline in the next year or two, which I'm very excited about. So the point being, we were seeing a lot of this. And it seemed like these guys probably were not being counseled appropriately. So what we did is we decided to do a secret shopper study. At the time, I think I was 34. So what we did is we identified 50
Do you
direct.
sleep in Tupperware because you're like aging backwards?
Hey man, you just got to take care of yourself, dude. You look great too. You aged backwards too. You know that. You
That's
look,
the 70 pounds I lost, I think.
yeah. I mean, listen, at one point I weighed 235 pounds, but that was in high school when I was playing football. It wasn't sustainable. And then I've lost weight throughout. But I really am a believer, practice what you preach. Try to get good sleep. I exercise 5 to 6 days a week, weightlifting, playing padel,
Badly.
getting some cardio. So it's important, right? Eating healthy and all of these things, because if we're going to be on top of our game, taking care of patients, we have to take care of ourselves first. And that's really one of the biggest messages for men, right? Just as an aside to the men's health thing, right? Men, we picture ourselves as, this strong guy, the best partner, the best father, the best colleague, the best friend. But you can't be the best version of yourself if you aren't really taking care of yourself. You're trying to take care of everyone else. You got to take care of yourself first. And that's why it's important to go see a doctor, to go talk to someone.
Yeah,
But
you
back
can't
to the
fill from
story.
an empty cup. And I use the analogy that if you walked into a mechanic and he just had broken down, his own cars were broken down. I mean, how much are you going to trust that guy, right? So the same thing with the doctor. If you walk into a doctor's office and they're unfortunately overweight or unhealthy, or they're standing outside of the hospital smoking, is that something that you want to take advice from? Is that someone you want to take advice from? I don't think so.
I think that's fair, but I'm also going to come back at you, because there is a level, and we've all experienced it, right? There is a level where you can be a very smart, talented physician. And, unfortunately, there's people who this is their life, and they will commit everything that they have in their being to this. And their health goes to the wayside. I think that I can see both sides, and I think it's very fair. But there are people who, we're all human at the end of the day, right? I looked at the data, we did a survey, we looked at male physicians. We know that they're higher risk for low testosterone, higher risk for erectile dysfunction, male fertility, because, as we both know, the lack of sleep, the long hours, the high stress, your cortisol spiking, it's hard. It's very hard. We have to make a lot of effort. We both do. We both know to, you have a kid. I don't have a kid, so it's easier for me, right? Like, it's, to be honest, so anyone with parents and with kids, and you're a doctor or you're a professional, I don't know how the hell you do it. It's amazing. You guys are the real superheroes, but
You know what?
it
I
goes
I
both ways.
will I will agree with you there, and I'll retract that statement, because you're absolutely right. There is You look at plenty of coaches on the sideline and they're amazing coaches, but maybe they're not, completely fit the way they, and you're right. You don't know anyone's circumstances and you don't know if there's an underlying issue there. And I guess we should look at patients the same way.
Yeah, I mean, listen, that's a great point. I think that you've seen patients, I've seen patients who come in and you're like, okay, this guy's overweight. He's probably not doing anything that he needs to do. And no, they're coming because, hey, doc, I've been on a diet. I've tried this diet. I've tried, exercising. I don't have the energy. I don't have the motivation. I don't know what's going on. Guess what? You diagnose them. I diagnose them with low testosterone. And, 10 years ago, people would have been like, well, just keep losing weight, eat healthier. No, we know that's not the case, right? Give them the testosterone, improve their testosterone. It's going to help them lose the weight, give them the energy to go to the gym, give them the metabolism they need. Maybe find that extra motivation to eat a little bit healthier, get better sleep. A lot of guys get much better sleep when they're on testosterone, but we also have to screen for sleep apnea for obvious reasons. But, so it goes both ways, right? Yeah, obviously I want everyone to be healthy. I want my doctor to look healthy, but there are limitations for everything. And I tend to try not to judge a book by their cover.
That's a great way to say it. And that's exactly why these sort of discourses are necessary. And, you should be able to change your mind if there's better evidence out there. And that's exactly what happens when two docs get together. I did want to go back to your study. I know
Sorry
you didn't
about
get a chance
that.
to finish it. I have a tendency to interrupt when I get excited about, something
No,
and,
this
and
was
I'm
good.
talking to my buddies.
This was an important conversation. Basically what I did, I was 34 years old at the time. And we identified 7 companies that were doing direct-to-consumer TRT care, testosterone replacement therapy care, in all 50 states. And what I did was I pretended to be a patient. It was a secret shopper study. So we came up with a script that gave me the signs and symptoms of low testosterone. Said I was in a relationship, but I wanted to preserve my fertility. Very important. So when we're addressing men's testosterone, right, and we're seeing them in clinic, the first thing we're always asking is, do you want to have kids in the future or not? Because that's immediately going to give us, a different stratification of how the tools we're going to use to treat patients, right? There are fertility sparing interventions, Clomid and Clomiphene, HCG, or you can combine things, but in straight TRT, giving test SIP straight up, it's pretty much a contraindication if you want to have kids. So, I said I wanted to have children, and then I had signs and symptoms of low testosterone, and then I got my blood work, and my testosterone was 675, not to brag, pretty good. To give our listeners, we'll go into ranges, I think, a little bit later in the conversation. The AUA guidelines say around 300 total T as a low end, goal range being, the second tertile, which is about 450 to 600. But realistically, we can go to under 1,000 is where over 1,000 is where we see supra therapeutic levels. But, 675, no question. I was not in range of being a good candidate for TRT. And despite that, so I was 2 for 2, right? Very normal testosterone, wanted fertility. 6 of the 7 companies offered me testosterone therapy straight up. And only half of them discussed the fertility risks with me. And when you look at that, it was, surprising, but also not so surprising based off of what we had experienced in our clinics. But, it was very enlightening, because what we realize is, there's a lot of stuff that's going against the guidelines out there. There's a lot of practices that are not practicing within the guidelines. Now, are the guidelines perfect? And that's another conversation. The answer is no. In fact, they're redoing the guidelines right now as we speak. In the next year or two, they're going to be updating the AUA, the urology guidelines. There's also the endocrine guidelines, right? The urology guidelines don't even include free T right now. The Endocrine Society does include free T, but there's, the Endocrine Society gives less of like strict, numbers. They give some numbers, but they're like, it kind of seems low. So, there is an art to all of this. And what I tell my patients, and what I tell, a lot of listeners when I talk is, physicians, we live in the gray, and it's okay to live in the gray. If my testosterone level on that was 375, I probably would not have had like we were joking around. If my testosterone was a 375, yeah, I don't think it's an interesting study anymore. Right. And that's the truth. So, I was lucky that, my testosterone was very good because I take care of myself. But, if it was in the gray area, it's less of a conversation. So, it's enlightening because we have to empower our patients. And this is important for our patients and important, for direct to consumer companies to understand that, we need to do better. And when you're going to these practices, you need to ask, like, what are my goals? What are the risks of these medications? Because clearly we weren't being counseled appropriately on the risks. And what are the long-term impacts? And, who's giving me this? What's their experience and things like
Yeah, I mean, I have nothing against these direct to consumer companies and the telehealth TRT. I just because I practice telehealth as well. I
that.
have
Yes,
I have a
I do
concierge
too. I
internal.
do too.
Okay, a concierge internal medicine practice with very few patients now because I've got the corporate role, but we also do telehealth at game day. And so I've got nothing against it. My only issue with telehealth, and I've been practicing telehealth since 2018, is that I've almost never seen the same patient again. The telehealth companies will pay you per clinic, like per consult. So what they're trying to do is try to get you to see as many patients possible in the shortest amount of time possible. And as a physician, if you're getting paid 30, $40 a consult, imagine how many patients you have to see to pay your rent in Miami.
Yeah.
So that's sort of like that's where the trouble starts, I think, with telehealth, and you don't have that continuity of care. So you might be signing up for one of these, direct to consumer TRT plans, and maybe they're doing the right thing. Maybe they're actually asking the contraindications for, testosterone replacement therapy. What's funny is in my own personal game day clinics, I've got a stand up banner that says the contraindications to TRT. I get it,
That's
all the
awesome.
all the
That's
great
awesome.
stuff that's out there, you go online and you're going to hear all the amazing things that TRT are going to do. But when you sit down in my consult room, the first thing you're going to see is the contraindications to it. And are you planning on having children within the next 6 to 12 months? Have you had a heart attack or stroke within the last 6 to 12 months? All those like big things. I'm like, listen, this is what and what happens, the side effects of TRT. I'm like, we go through that first before we talk about extolling the benefits of it, so the patients are aware. And that's the right way to do it. So maybe there are TRT companies online that are doing that, but how many of those have continuity of care? You may see, an NP, a PA, a doctor, and then are you going to see that same doctor, PA, or NP again? Probably not. Who's going to be following up on your labs? Most guys that start TRT, they're not getting labs when they're doing with these direct to consumer companies. And who's following up to make sure that they are? And you might see 12-month labs where somebody's coming in and their estradiol has spiked, or they've got a hematocrit in the high 50s, and that becomes a little bit dangerous as well. So that's my concern. And when we started our TRT online programs, our telehealth programs at Game Day, my first thing was I want to make sure that whoever you're seeing, you see again. And so when you sign up for a telehealth program with Game Day, there's a practitioner 3 hour, 3 miles down the street that you can go in and see. That's what the benefit of having 430 locations open. And that's my take on telehealth HRT. So there
No,
are
I think
great practitioners, but
I think that's a very important insider, right? Information right there. That's really good knowledge for the listeners. I do think that the continuity of care is huge. I cannot stress that enough, right? You want someone who knows who you are, who's seen your labs, who can actually understand your story and trend it. When we're looking at direct to consumer, once again, I think a lot of people when that came out thought I was like bashing direct to consumer. It's not really to bash it. It's to acknowledge, listen, direct to consumer, you and I both know is not going anywhere, right? Men do not, they don't
you
want
don't have
to,
time.
they don't have the time. They don't want to go sit in an office because of the shame associated and the stigma associated with many of the health issues that, are associated with low testosterone or erectile dysfunction. But also, we're in Miami. Access to care is easy. But there's a lot of places in this country where, from a urologist standpoint, I think only about 60% of counties in the United States have a urologist. So there's a good portion of people who can't get access to a good provider like you, or get access to a urologist or someone who has knowledgeable information on testosterone. And the direct to consumer is a good access place. But, the point is, when you're going through this process, you have to understand what the risks of these medications are, what the benefits are, and then, choosing a provider maybe that fits with you, and maybe asking about, is there continuity of care going on here? Is there what else, what are we looking at here? Another thing that was concerning to me in this study was when I would ask, what is my goal testosterone level? Some would say, we're going to keep going until you feel better, which is kind of crazy, obviously. We had some people say, at least 1500. So, these are very high super therapeutic levels that when we talk about testosterone replacement therapy in general, very, very safe and overall very beneficial. But when you're super therapeutic above 1000 consistently and blasting off to 1500, 2000, that's when you're seeing all these other roid rage kinds of things that you see in, all the media and all, the old, public service announcement kind of things. So, you have to ask the questions. And I always encourage people to do their own research, understand things, listen to this podcast, listen to my podcast, listen to some professionals who really know their stuff. And that'll help guide you, and you can be your best advocate in these situations.
Yeah. I mean, let's talk a little bit about the ranges, right? So if you look at AUA guidelines, like you said, it's 300 is considered low. If you look at the Endocrine Society, 264 is considered low. Now, when I started hormone replacement therapy last year, my testosterone was sitting in the 400s. And my wife, who's an internal medicine physician, said, "No, you're fine." And I'm like, "I'm not fine. Working out, I'm not sleeping well. I'm, constantly just felt brain fog. I wasn't putting on any muscle. I wasn't able to lose the belly fat. Put myself on hormone replacement therapy, and all of those things changed. And it took a while. It took about 6 to 9 months really to start seeing body composition changes, but almost a mental changes started happening, I would say within 4 to 6 weeks. Now, my total testosterone, I'm comfortable sitting at between 900 and 1200. But I really look at my free testosterone. That's the more important number, because that's going to be the available one. Now, the TRT ranges on the lab values, they go from 300 to 1200. So above that is considered super therapeutic. Below that is considered subtherapeutic. Both are dangerous, and both can have, cardiovascular effects, neurological effects. You have that breakdown of collagen and elastin on the endothelial, subendothelial tissues, and that's where those guys go into the ER, and they're, testosterone's at 2500 and they've had a dissection. Those are the calls I get from my ER buddies that, "Hey, we just saw this guy with a T of, 3000 coming in from a
Yeah.
med spa," or something like that. So there are guys, and I've talked to a ton of men's health experts out there. I would argue that 1000 isn't super therapeutic. I would say closer to 1500 would be super therapeutic, depending on the person, depending on the patient. A 38-year-old guy who's done having kids, who's young, who's healthy, that's somebody I'm okay running hotter, quote unquote, versus somebody who's a little bit older, has more comorbidities, is a little bit riskier to run, a higher total testosterone. But, total testosterone, again, how much does that matter versus the free testosterone? And then let's talk about a little bit of the other ranges that we look for in, estradiol, hematocrit levels. So yeah, just wanted your take on the TRT ranges.
Yeah, listen. So as a urologist, I do tend to go by the AUA guidelines. 300 is low, but when we treat, our goal is at least 450. So I call that 300 to 450 range kind of like the gray zone. And in those situations, you're really looking at the patient and figuring out what's best for this person, what's their situation, what's going on, how are they feeling? Because you and I both know that there's guys who live in 430s who are completely normal, have no signs and symptoms, are very happy. And I'm not just going to give someone a medication if they're not
Sure. Let's
symptomatic, right?
yeah, let's clarify that there is testosterone, like low testosterone, and there's testosterone deficiency. Those are two different things. There's the number and the symptoms, and you need both before you get treated.
Correct. And just treating someone to treat someone is not something that I think anyone wants to hear, or, that's not my goal as a doctor to be, just giving you things to give you things. Now, having said that, if you have a low testosterone, you feel okay, and you have like a chronic inflammatory disease, you have some kind of, you have HIV, you have like, some kind of autoimmune disease, I will have the conversation potentially about maybe doing something about it, right? Because I think that these chronic diseases, when you have them for so long, there is some level of like inflammatory that your baseline that may not be the actual baseline of what you should really be feeling. So it's hard. It's hard, and this is where we live. We live in the gray, and really understanding. And this is where it's important that people are not just numbers. They are a story. They have their own individual, beliefs. They have their own individual health issues, and how they respond. Everyone responds differently to everything, and their health issues as well. So I think the 300 to 450 area for me is much of a gray zone, where we're trying to have a conversation whether to treat or not treat. Typically, if you're higher than that, I'm really not treating you. My goal is always below 1,000. Now, when we look at the numbers, though, if you're injecting test SIP, obviously at some point you're going to be above 1,000 during your weekly injection, and that's realistic. But my goal is, to not be persistently living above 1,000, right? I think that there's a difference there in understanding that, testosterone cypionate, for example, is typically what I like to give a lot. It's what I like to usually start with. It's a half-life of about 7 to 8 days. So when you inject that first day, your testosterone is way higher than you should be. And we understand that. That's why also, when guys come in, they're doing every 2 weeks. I personally prefer every week based off of that, because I don't like getting those really high highs and those really low lows. And, more frequent injections, obviously you can plateau and keep a more steady state. But back to, the levels, I think an important distinguishing thing is understanding total testosterone and free testosterone and SHBG and all these factors, because, when we look, the AUA guidelines, the old one, current one, only mentions total testosterone. You already said the Endocrine Society also includes free testosterone. So total testosterone, all the testosterone in your body, right? Free testosterone is theoretically like what is not bound. So things are bound to testosterone include sex hormone binding globulin, which is tightly bound to testosterone. So that's usually not available readily to be used. And then you have albumin, which is loosely bound to testosterone, and that's considered bioavailable. So if you see a lab called bioavailable T, I typically don't use that. I usually really just use free T and total T. But the free T is only about 1 to 2% of the total testosterone, which is the testosterone that's not bound to anything and is really ready to bind to your receptors. And that's theoretically the more important one, because it's what you can actually use. So I have, over the years of reading the literature, seeing more patients, I have significantly increased my usage. Pretty much everyone gets a free T at this point. As well as an SHBG. And, I think there's a very important distinction between labs here, because the labs can get confusing for SHBG because, not SHBG, I'm sorry, free testosterone. Because oftentimes I have a patient coming is like, well, this lab says my free T is 7 and this one says it's 65. But the units are the same, picograms per milliliter.
Yeah.
Why? And, this is a very important distinction, I think, because there's two different kinds of assays for free testosterone, right? There's the direct analog immunoassay, which is very available. And this is the one you see the ranges of like 6 to like 17 picograms per milliliter. This is actually really not accurate. This is one you really don't want. The Endocrine Society, I think JAMA also did a paper saying like, this is not an accurate assessment of your free testosterone. When I look at that number, I don't really have a good cutoff of what to use, because it's really just not endorsed by many people. And yet we still continue to have labs on it. And even when I order labs, I don't know why sometimes the free T comes back as an immunoassay. I think it's randomly whoever's drawing the labs in the bar. In the lab.
You're already
Sorry,
thinking
it's
about
Saturday.
tonight.
It's Saturday. You know where my mind is, dude.
Yeah. By the way, it's Saturday morning, and this is the only time we could, make time to jump on. So that's another thing, being a doctor in Miami, right?
Absolutely. And then, but the real important one is actually the like the equilibrium dialysis is like the gold standard. It's the calculated free testosterone, right? This one ranges, usually it says, I think the range is like something 37 to, 75 or something in picograms per milliliter. For my cutoff for that is around 46 for the total for the free T is typically what I like to see your free T being higher than. Because free T, especially with the AUA guidelines, I have never really seen like a goal free T out there. And I think that's another issue. And that's something that we've really come to learn, right? So I still use my goal as the total T, which I understand can be problematic in a situation where sometimes I'm treating the free T more than I'm treating the total T, but I'm also treating the patient. And if they're feeling better and I feel good about where their levels are, then I'm okay. So obviously, I'm saying a lot of very complicated things, but let's pull back for a second. And I just want to make it very clear. It's not very easy. There is a lot of art to medicine. There is a lot of gray. And I just wanted to kind of give you a little background here. And this is actually the most detail I've gone in on a podcast about all these things. But I want people to appreciate that, we're thinking about these things very, very intricately. And like, the labs matter. Where you get the labs matter. How I see the labs matter. Your health matters. Your plan matters. What you want to do with your life. All these things decide whether you're a good candidate for testosterone. Comments. Sorry about that, man. That was a long rant. I hope that
That
was
was
helpful.
awesome. That was awesome. That's exactly what I think our listeners want to hear. I'm going to break it down a little bit more for them. So when you compare lab assays across the board, you're going to see differences between 20 to 40% sometimes, even in the same day. And this is something that the AUA actually mentions in their 2023 update of the TRT guidelines. So I tell patients, look, if you're going to compare Quest and LabCorp and the internal labs, you're going to see differences. You're going to see variations. You're going to see up to 20 to 40%. Shoot, if you compare the same lab within the same day in a patient that's not hypogonadal, you're going to see a 20 to 30%, diurnal curve, that diurnal curve that everybody talks about with TRT. 5 a.m. in the morning, it's going to be, 5 to 7 a.m. in the morning, it's going to be highest. And then 5 p.m., 7 p.m. in the evening, it's going to be lowest. There's something to be said though about someone who's truly hypogonadal. That curve disappears as you get older. That curve disappears. I'm noticing that guys younger than 40, 45, yeah, there's going to be a difference between 20 to 30% throughout the day. Later on, in their 50s and 60s, it becomes like 10% the difference. And then a true hypogonadal, meaning a truly testosterone deficient person with testosterone deficiency and low testosterone, that almost disappears. So there's some nuances there. Also, like you said, if you're injecting once a week, your testosterone is going to peak in that first 24 to 48 hours. So if you check in the first 24 to 48 hours, you may have a super therapeutic level, but what happens the rest of the 7 days? You may come, within line. So what I've started doing a lot of over the last couple of years is I don't dose once a week anymore. And I know, if you go to a primary care doctor, it's going to, unfortunately, that's how they're going to dose. They're going to dose once every week, once every 2 weeks, because they maybe don't understand the nuances of that. They've got a lot to do. It's not their cup of tea necessarily. So what I've started doing is twice a week. And what I've noticed is if you look at the pharmacokinetics, 3 times a week actually works the best. It's really smooths out that curve. It becomes almost like a physiological testosterone release. And that's where the guys feel the best. And that's where you can actually have an average testosterone a little bit higher, but you're not in the super therapeutic ranges where it's dangerous. And these guys feel amazing because there's no peaks in, the roid rage that you're talking about, that most people talk about. That roid rage is usually because of a high estrogen level. It's not necessarily because of a high testosterone level. How does that work? When you inject once a week, the first 24 to 48 hours, you get this peak of testosterone. Your body's going to use up here, what it needs, and then convert the rest in adipose tissue and fatty tissue to estrogen, estradiol, which is good for guys at a certain level. When it gets beyond that, you get sleep disturbances, mood issues, you'll have irritability,
Nipple
like
sensitivity.
how a woman's going to feel right before she gets her period, and that's what guys feel, and that's where that roid rage I think comes in. So yes, you're absolutely right. You can't, you got to treat the patient in front of you. If you treat the labs, you're going to be off all the time. If you stick to a protocol, you're going to be off all the time. It's treat the patient in front of you, look at their goals, look at what they're trying to do, consider their age, their comorbidities, and then you decide on what you're going to do. That 450 to 600 range that the AUA has put out there for us. You know who they put that out there for? They put that out there for the internist that's seeing 2 hypogonadal patients a year because they needed a safe sandbox for them to play in. Someone who's going to see their patients 2, 3 times a week, like we can in our concierge practices, it's a little bit different. I think it's we can monitor a lot closely. It's going to be a lot safer. So that's the difference, I think, between going through a telehealth practice where they might pump you up higher. It's probably not the safest thing to do. um, yeah, we could talk about this for
Yeah,
hours.
no, I want to just comment on the estrogen as well, because yeah, I think you bring up a good point. 10, 15 years ago, we used to have this, like the whole space was testosterone man good, estrogen woman bad. And that obviously isn't
You
the
sound like
case.
an orthopod there for a second.
Yeah, exactly. I just feel like it's like a caveman thought, it's just like this, like,
My ortho buddies are going to destroy me after this.
yeah, no, they don't really say the words testosterone. Although I've actually really been pushing. I'm trying to do some more research in it. One of the true benefits of taking testosterone, especially in the elderly population, when you look at the literature for orthopedic surgery, replacements, and recovery, men with low testosterone have significantly more complications for replacement surgery. They have longer hospital stays. They have longer PT requirements. So, I've really been requiring or asking a lot of the ortho people everywhere I go. I send them all the literature. And obviously, a lot of these things can't wait to be just treated, right? You have a hip fracture, you got to get the hip repaired. But if you're taking your time and you're going to get a knee replacement in maybe the next year, it's worth going to your urologist, getting a testosterone level, and seeing what's going on, because that can actually significantly improve your outcomes for your surgery as a patient. So anyone who's struggling, right? Osteopenia, osteoporosis are actually signs and symptoms of low testosterone. So
Correct.
these are actual things you can do to improve your bone health, reduce complications in surgery. In the literature in orthopedic surgery is incredibly strong, suggesting that these things really make a difference. So if you are someone who's struggling with knee issues, elbow issues, hip issues, shoulder issues, and you're going to probably need a replacement down, you're better off go see a doctor, get a testosterone level, and see if that's something that can help you. Not necessarily, it's not going to cure your knee or hip issue, but if you do need surgery, it might improve your outcomes and your recovery, right? Because you're building muscle, you're helping your bone health. So that recovery is going to be a lot easier for you in the long run. So just another side note. So back to the estrogen. Estrogen, really important. We used to think it was bad. It also plays a really important role in bone health, going back to bone health, as well as libido. So, these guys who've come in, and we've both seen them, who are just blindly on an anastrozole or letrozole, it's just not a good idea, right? Like I actually really try not to put people on those medications unless it's really indicated. And when is it indicated? So what I like to see is I like to see a total testosterone to estrogen ratio greater than 10-1. Because you already said that, testosterone in the periphery is converted by adipose tissue to estradiol, a percentage of it. So naturally, when your testosterone goes up and we treat your testosterone, you're going to have an elevated estradiol to some degree, right? And that's why, like, I don't stress too much about it unless a patient is
Symptoms.
symptomatic, unless they're complaining about the things that you're saying, as well as nipple sensitivity, things like that. Then I'm saying, okay, maybe we do need to address this. But otherwise, I'm okay to kind of let the estradiol do its thing. I don't think that there's insanely, if you're asymptomatic, once again, less is more in my opinion. So I try not to treat it unless you really need it, because once again, if I put you on an anastrozole for long periods of time, about a year to 2 years, I want to get a DEXA scan on you. I want to see what's going on with your bone health, because theoretically they can put you at higher risk for osteopenia, osteoporosis. Although I'm putting you on a very low dosage, I still want to make sure we're not damaging your bone.
I have this method with patients, and this is one of the side effects that I discuss during my consults, and I let them know exactly like that. Like if I'd like to go with multiple times a week dosing so that we can avoid these peaks. But if I see an overweight guy, I know he's going to convert. I know he's going to have some level of conversion in the fatty tissue. So what I'll tell them is, you probably should be on weight loss medications. We'll talk about the
Always,
diet and exercise
100%.
and nutrition, and we'll give them plans, but it's difficult. It's difficult to lose weight. You and I know how difficult it is to
Yes.
lose weight. So I might put them on a 3 month, 12-week, really intensive, just GLP, one plan along with the diet and exercise,
Awesome.
and negate the use of anastrozole completely, because my goal is never to use anastrozole longer than 90 days if I even have
Absolutely.
to use it. Um,
Absolutely agree.
and I'll lower the dose. I'll if I see somebody starting to convert, I'll tell them, look, it's better we'll split the dose and we'll lower the dose so that we don't have to add on more medications. I almost look at it as it like it's a failing of mine, because I put them on a medication and then I cause a side effect. And now I'm putting them on another medication to cure that side effect. Why not get rid of, I hate this word, the root cause? So,
Well, I think bring up the root cause, though. I love this. I love the root cause. Give me the root cause, because I think that a lot of people on social media go, your doctor doesn't
treat the
doesn't
root
care
cause.
about the root cause. Come to me, some random guy who's jacked with a six pack, who's standing in the sun, and I will tell you the root cause of your disease, because no doctor in the last 500 years has ever figured it out, except for me, coach guy who just sits in the sun all day and just probably takes TRT and doesn't tell you the truth. But yeah, that stuff bothers the shit out of me, because
We'll edit that out.
obviously I'm
Sorry,
passionate
Mom.
about it. Yeah. Bothers me because of course doctors are looking at the root cause. Like, what do you think we're looking at? When we, looking at low testosterone, we already identified so many things that are at the root cause of low testosterone, but that doesn't mean that giving you the medicine isn't ignoring those root causes, but it is part of the treatment, right? And I think that that's very important. I like I said before, 10, 15 years ago, they used to say, oh, you're fat. Oh, you're tired, sleep better, go to the gym, eat healthier, lose weight. Sorry. No, we know that treating you is going to help you in this process. Giving you GLP-1s is going to help you in this process. People are struggle. And like, to just say that doctors are ignoring these things, yeah, I can preach diet and exercise till the sun comes home. Humans have been around for what, 20,000 years? I have no idea how long. Yeah, everyone on earth knows diet and exercise is good for you. But guess where we are as a society? We're more obese as a society than ever. We're more sedentary. We're eating worse foods than ever. And yet just telling someone to diet and exercise isn't fair. It hasn't worked. We need to provide realistic solutions, GLPs, replacing testosterone when it's indicated, help people where they need it. And that's something that I think a lot of people really struggle with. And because it's not easy. Diet, you said yourself, I lost like 70 pounds with diet and exercise. It took me like 4 years, 5 years to do. It doesn't happen overnight. And it took a lot of work. And then, adding kids, adding a stressful job, adding life, like things get hard. You need help. It's okay to get help. And, some of these things will really get you where you want to go. But to just say that we're not treating the root cause, I think is just crazy.
I mean, and those same, influencers that say that doctors don't want to help you and we can, and we've got the root cause, they've usually got an affiliate link to some supplement that's been completely unregulated. And guess what? They're still selling you a medication. It just happens to be a completely unregulated one. And as you can see from this conversation we've had so far, medicine is very nuanced, and you're never going to hear a doctor say that this is the end all be all and the cure for everything. We just don't operate that way. Our brains are wired to think of a million different things and treat the patient in front of them. And like you said, meet them exactly where they are. It may not be the answer for the patient in front of you, whereas some of the folks out there will have you thinking that they have figured something out that the 2-3 million doctors in the world just didn't. I mean, it's a little bit that's shady. It's just shady. I'm gonna switch to, we talked a little bit about a gray area, take on peptides. And next month is the FDA meeting with we're discussing, I think, about 7 different peptides that have been on the docket for the last 6 months or so. There's a bunch of peptides that are FDA approved. There's GLP-1s are peptides. I'm going to be up in DC having that discussion as well.
That's cool.
What is your take on peptides?
So, I think peptides are very interesting. It's a pretty exciting time. Obviously, when you look at the history of what was going on with this peptides, you had Dr. Tatum on, who is obviously one of the most knowledgeable guys in the space. They disappeared for a reason we really don't understand, and that's what's going on in the next few months. We're investigating whether we're going to bring back those banned peptides from that list. I think BPC, there's just a lot of them, but I think that there's a place for them. We just need to understand what that place is. I think currently what I worry about, and I have a lot of, we're in Miami. Everyone's on peptides. Let's be honest here, right?
Yeah. The nail
I have a
salon
lot of
selling peptides.
what?
The nail salon is selling peptides in
Yeah,
Miami.
exactly. And my doorman's probably selling peptides, and he's got a good connect. I have no idea. So, the thing is that the gray market is a problem, right? I cannot tell you if a peptide works or not, because one, I don't even know if you're getting what you're saying you're getting. Two, I don't even know if the dosage is accurate. So how can we accurately assess a product for efficacy if we don't know what the product is, if it's there, or how much it's actually being given to you? Obviously, contaminant is a concern. It could be lead. There could be other bad things going on. We already see that in places like whey protein and creatine. So how could you not believe if those things have contaminant in them that, other things don't, like peptides, which are truly gray market? I've had, I think a lot of people may have heard of SARMs in the past. I did some research on SARMs, and, SARMs are interesting because they were originally touted to be this perfect molecule, like Clomid is a SERM. So Clomid is a SERM, selective estrogen receptor modifier. SARMs are selective androgen receptor modifiers. The thought process was that we could actually endorse or promote muscle growth in the androgenic pathway without the side effects by just targeting, just the androgen receptors. And it was thought to be a very powerful thing. They looked at it for cancer patients who were cachectic, and it never came out positive. It just never really worked out for whatever reason in the literature. But yet it had this bro science behind it, where you can still purchase some SARMs online as research chemicals, just like peptides now. And I've seen over the years a lot of men. We were actually the first ones to really publish side effects on SARMs that were purchased online. We actually couldn't get real information. If you look it up, we went through Reddit channels and we did surveys of men who have been taking SARMs and the side effects. And, they did have, like, they were taking testosterone side effects. And some of these things were contaminants. I've seen men who come in, they've injected SARMs twice, and they have lost their libido completely. They have developed erectile dysfunction. I'm talking about 25-year-old men. And that's the risk of all these, chemical research products, is that we don't have a regulatory, it's not meant to be injected. My stance on peptides is, I think there's data on them, right? Testosterone, sermorelin, they've been FDA approved in the past, right? Like, there's good data on those.
Tessa still is FDA approved in
right, exactly.
HIV males.
Exactly. In HIV patients, you're losing that visceral abdominal fat. I think there's a place for it. What we're starting to look at least for me, I'm interested in using those in men who, I've been starting to offer it for men who are hypogonadal, who are on things like, who have metastatic prostate cancer, who can't go on testosterone, and they're developing visceral body fat. And I think there's a really interesting role in things that we can do in this space. Now, obviously, we don't know, right? There's theoretical risk. Is growth hormone, could it put you at risk for spreading cancer? Things like that, we don't know. And this is what we have to research. So, I'm hoping to do some research personally in the space. That's one of the reasons I have great resources at Baptist Big Health Center. We have a big cancer center that I'm part of. So we're starting to explore ways that we can use peptides in a very meaningful way for people who may not have access to other things, right? There's interesting roles for things like NAD+, which are not necessarily peptides, but these are also hot. But, we don't know what we don't know. I think that we do have to research these things. I think having them FDA approved is going to be important, because we're going to, at least in the minimum, provide people with good, clean, safe resources for usage of these things, so that not everyone and their uncles are just buying them off the streets. So I think it's an exciting time. I think that a lot of potential, and to provide a safe means to get these things is actually the most important thing, in my opinion. What are your
You
thoughts?
know, it's that's just thinking about Baptist being the largest. Basically, it's the largest health system in South Florida, and you are the head of sexual health for arguably the largest health system in South Florida. I smell a collab because we are the largest men's health clinic in the world, and we have the patient population for to do probably incredible work in terms of studies. We're doing some white papers already, but uh, I think we need to talk a little bit more about possibly doing a collaboration with.
I'm always down, man.
Yeah, that would be wow. That actually got me really excited to think about because I don't know why I didn't think of that sooner. I mean, I was thinking about other universities, but I'm like, you're in my backyard. We should definitely make this happen. Um, let's shift over to a little bit more gray area. Exosomes, stem cells, Mcella chairs, all these things that are out there in regenerative medicine or regenerative, men's health that you're seeing out there. Tell me your take on. Let's start with the most basic PRP. Now I'm going to talk a little bit about PRP. I've used PRP in my career in internal medicine and geriatrics with great success. With patients who are the Medicare population who we couldn't really even get reimbursement for, but we would have lines out the door for patients who were coming in for PRP for joints, for regenerative joints, and these are 60, 70, 80-year-old folks who have degenerative disease, and we would inject them with PRP, and they would have spectacular results from it. Now, how much of that is anecdotal, how much of that is placebo effect, how much can actually be placebo effect when you're that much older and you're having that much pain, and then things start to improve with it. And then I see the same thing with PRP for penile rejuvenation, but I'm seeing that more with younger guys with more mild disease do really really well with it. And then as you get older, and I guess your PRP gets older, the effects are not as pronounced, but they're still seeing pretty decent effects. And I think that's where maybe more study needs to happen, because you and I talked about this before the show. There's studies that show it's great. There's studies that show it's not great. There's no uniform methodology
Protocol.
to it. Yeah. So talk to me a little bit about, let's start with the most basic PRP for the penis.
So yeah, I think the first thing I'm going to say, right? I'm been a former chair of one of the chairs of the Sexual Medicine Society in North America. Is really one of the biggest sexual societies in the world, and their statement on stem cell PRP and all those things is that they're strictly considered experimental and for research at this time. There's a lot of clinical trials that are still always ongoing because people are exploring this because it's a very interesting space. But so they recommend that if you're doing it, you should be part of a clinical trial. Having said that, we also live in reality, and we also live in Miami, where we see this all the time, every day. And I think that it's important when we're talking about PRP, understanding, right? Like, so the PRP, the theory is that it's like recruiting growth factors, angiogenesis into the area of desire to help heal or regenerate. And when we're talking about erections, pretty much all of the treatments we have right now are not regenerative, right? Regenerative is you are regrowing, you're bringing back nerves, you're bringing back vascular tissue to help your erections be back to a baseline naturally, almost, right? It's your actual body doing the improvement here. All the medications, interventions we have are, we're just helping put a band-aid. We're overcoming, what obstacles your body is giving you to achieve an erection. And that's not a bad thing. That's just the reality of what we have as options. And most of the time they work pretty damn well. But when PRP, I always found it interesting because when you were talking about injecting in joints, these are encapsulated areas where the PRP kind of sits. Your penis has a lot of blood flow going in. That's the whole point of it, right? So a lot of the times, like, it's very hard for me to understand like how PRP, how the stem cells and all these things work. They often do put a tourniquet. They do a tourniquet for, every protocol has tourniquet on. I don't know the protocol, 20, 30 minutes. I think everyone's protocol is different to theoretically, make sure the PRP stays in there during that time. Can we prove that? I don't really know. But, there has been data on PRP that it has worked, but there's still a lot of heterogeneity, meaning, conflicting results, right? The biggest study out of U Miami showed that there was no changes. There were several other studies that showed there were changes in erectile dysfunction. Um, I think a lot of the problems with this is that every single protocol is different. They're using different machines. The preparation is different. How often they're ejecting. And when you talk about mild to moderate erectile dysfunction, there's always theoretically a placebo effect, right? You inject something in your penis, you're feeling, you already had an injection in your penis, you're probably feeling like, you did something. And if you have mild ED, maybe that's literally all you need to get over the hump, proverbial hump, literally or figuratively, to achieve the satisfactory erections that you need. Also, the problem is the data for these studies only goes to about 6 months out. So when you're looking at long-term impact, we don't really know what it is. Is it truly restoring you, or is it something that has a placebo or a temporary impact where you need these shots every 6 months to a year? And the truth is, these are cash pay. They can be very expensive, in the thousands. And, the thing I find in Miami specifically that I find disheartening is you have guys with severe, severe ED. They come in, they see me, they go, listen, I haven't had an erection in 10 years. I had a prostate removed. I've tried Viagra, I've tried injections, I've tried Cialis. I just spent $8,000 on this protocol or that protocol, and nothing worked. I could have told you that it wasn't going to work, right? Because I think if you're actually interested, like you said, I think any of these more experimental things are probably best for that mild to moderate to get any improvement whatsoever, if you're going to get an improvement. And that's just my gestalt on it, because of the fact that, you really don't need that much to get back to your baseline. But if you have significant ED where Cialis, Viagra, none of these things are working, injections may be working, I don't think that these are all realistic options for you. I think you're getting, push the fountain of youth for something that won't work. If you're in the mild ED and you say, hey, I really want to get off medications, maybe these things can do it. But even so, PRP really does have mixed data. I'm not saying it doesn't work. I'm not saying it does work, but I think it's a user beware kind of thing where, you're going to be spending a lot of money for something that may not be working, and you're injecting something into your penis. The risk is low. Fortunately for PRP, the risk is very, very low, but I don't know if I want to spend $5,000 to inject something on my penis that's not going to work.
Yeah, yeah. I mean, there's definitely patient selection matters. Mild to moderate disease. A lot of times, I'm seeing pretty good effects with PRP combined with all the other well-known, well-studied interventions. But then it does break my heart sometimes when I get guys coming in and they're 67 years old and they tell us, I haven't had sex with my wife, in 5-10 years, and then they go through the different modalities that they've tried at different places down here, especially. And those are the guys that, they're sitting at my desk and they're telling me, what can you do for me, doc? And that's how I met you, is because I said, I can't really do anything for you here. I'm out of my scope. I'm internal medicine. I run Men's Health. We treat what we can treat. And then beyond that, I need to get the experts on. I need a sexual health urologist, trained urologist, that I can pick up the phone and send those complicated patients to. And that's really how you and I met. So it's kind of awesome that I can pick up the phone and send you those patients in our backyard here. But I wanted to talk a little bit about one of my pet peeves, the out of scope practice of medicine by med spas in the great state of Florida. And, when you have a med spa that you walk into and someone's getting a pedicure, manicure, Botox, eyebrow threading, and injections of filler, and then next to them you're having discussions about something as nuanced as HRT, as testosterone replacement therapy. And that's something that really, really bugs me, that you have aesthetic practitioners who are great at what they do. Because my wife has sent me to get Botox. Obviously, I don't do it, but
You look
there's a
great.
space
I
for
would
all
have
of
thought
it.
you had Botox. I thought
No.
I would have thought you had Botox. It was good.
That's just the lighting in here. But but it's something that's a pet peeve of mine, because it's almost like you're putting these aesthetic practitioners and you're having them do medical procedures, and it's or medical, treatments, and that's unfair to patients. And that's I say I'm a rabid patient advocate, and I'll die on this hill. Stay in your lane, stay in scope. If you're out of scope, there are places that you can send them to, just like how I send you my complicated patients. So I tell, and I say this for med spas out there, I'm going to send you all my Botox patients. Send me the HRTs. We can manage them. What's your take on that?
It's interesting because, we talked a little bit before we started recording. There's people who know a lot and there's people who don't, I think. And then, it's hard to know everything. And that's the truth, right? If you ask me about management of diabetes, I'm not going to tell you that I know how to properly, dose insulin or put you on all these things. And, I think there is something to be said, like, you come into someone who can fix every single problem. There's something, maybe there should be a signal going off that, why is this person literally think they can manage everything about my health? And I think that, it's okay. We are so subspecialized in medicine. In many ways, it's good, right? Where, we can go see someone who only specializes in this one thing, who does this thing really, really well. But we also have people who are generalists, and that's also good. But there's a fine line between understanding what people can do and what they can't do. And I think it is a fair point. And I think it goes back to the same idea as the direct to consumer thing, right? There's good players, there's bad players. But when it comes down to it, you as the patient have to really be your biggest advocate. If you're walking into some med spa and they're saying, hey man, I'll do your Botox, and why don't we just add on 100 milligrams of TRT and just get you going on that, that should raise a flag, but yeah, these things happen. Honestly, they happen, right? So yeah, I mean, I think that there are people who are doing it good. There are people who are doing it bad. Identification of those things is very important. And obviously, you can identify it, I can identify it, and you're doing a great job of, talking to these practices when you do identify it and saying, hey, let's work together, which is the right way to look at it. Not, hey, you're doing this bad, like, screw you. It's, let's work together. We can do this together and provide better patient care, is the way that you approached it. And I think that's the right way to do it. But I think at the end of the day, we have to educate. And this is why important podcasts like you have, like I have, we have to educate patients who are looking for care, what to look for in a good provider of care, and have them identify, what the problems of their care are, the risks of their care. And then, if they're not happy, and this is what I tell all my patients, I don't care what kind of care you're getting or who's giving it to you. If you want, get a second opinion. You come to me, you say you want a second opinion, I'll point you in 3 different people. I'm happy to give you a second opinion because, you should have autonomy over your body and you should have autonomy of your care. So, I always welcome more information and more people's information on your health. And if you have someone who's telling you this is the way to do it, you should only be seeing me or you don't need to see someone else, I think that's a huge red flag.
Absolutely. Absolutely. And part of the reason why I do these podcasts at, Saturday morning with urologists is exactly that. I want not just patients, but my clinic network to have access to guys like you who are super specialized, and we can ask questions of, one of the first things I did when I took over as chief medical officer was create a medical advisory board of different specialties, because men's health is not an endocrine specialty or a urology specialty or an internal medicine specialty. Men's health is everything. It's all of it. So I've got 20 different doctors, 20 different specialties, 20 different clinicians actively practicing within the game day system. And those are the guys that, I expect to also to reach out to their networks like I do. And we have a urologist on our board as well. And then I look at you guys as my unofficial urology board. And I've got, 20 of those guys that I can pick up the phone and ask questions to. And then we do on a weekly basis, a lot of these aesthetic practices, they'll have a 10, 20-hour course, and then they'll release these practitioners out to work because they need to get the volume in order to keep their businesses up. We do weekly, biweekly, monthly calls where it's coaching, teaching. I have a didactics day every week, and then we're accessible 24/7, via different channels. Those are things that are really, really important to me. I'm trying to sort of bring residency back into this. When I trained with, with mid-level providers, with the NPs and PAs. They were attached to my hip for 6 months before I would release them to the hospital and let them
Right.
sort of
Yeah.
practice on their own. And
100%.
that's that's exactly what I'm trying to do here at Game Day, because it is such a maligned industry, men's health, and I think patients deserve better. So that's sort of my goal at Game Day.
That's awesome, man. That's the right way to be doing it, and it's very clear you're doing it the right way. You're doing it in a very thoughtful way, and we're all trying to learn from each other, and I think that's the important thing. We have a great community here where, we're all working together. We're all trying to do better for ourselves, for better, which inherently becomes better for our patients, and creating networks, creating opportunities to continue to learn from each other, different perspectives. Because you've heard in this podcast, there's a lot of ways to approach everything in men's health, right? And there's not necessarily some cookie cutter way to do it. And there's not one right answer. Every patient's different. So, having every tool in your toolkit, understanding how many different ways I can approach a situation for the right patient really makes a difference in patient care at the end of the day.
Yeah. I say it all the time on podcasts. I say it, during my talks, whenever I'm on stage. Collaboration happens at the top and competition happens at the bottom. And I
That's
truly
great.
believe that. I truly
That's
believe
great.
that. I'm gonna pivot. We've been on for over an hour. I think it's been an hour and a half. Wanted to ask you a couple of fun questions. You
Okay.
trained in the Northeast. I was born in India. I was raised in the Northeast in New York City, and then did my residency in Chicago. You did your residency down here in Miami, and then you did your fellowship in the Midwest, and then you came back to Miami. What area is your favorite, and why is it Miami?
So this is actually, I think I said already, I think Chicago might be the best city in the world now. I like in the country. I think I'm grew up in New Jersey. I did my med school at Rutgers. I worked in New York City for a few years before I went to med school. New York City is New York City, but maybe it's because of us, like how we grew up there. I just find Chicago as probably the best city in the country right now. I love it. The problem is the winters. Excuse me, I'm sorry. I think once when I was at Rutgers, when I started waking up for surgery rotations, having to wake up at 4:30, but then setting my alarm for 4 o'clock because I had to spend a half hour defrosting my car and taking the snow off of my car, I realized I can't do this forever. And so the answer is inherently Miami. I mean, we're by the water. The weather is amazing. I love Miami. There's a lot to do. We can be outside all year round. So I can hang by the pool. We can go on boats fishing. I do stone crabbing. Next month I'm going with my friend Dr. Masterson. We stone crab together. We're actually doing mini lobster season, and we're going to go to the Keys. I mean, what is not to love about Miami? And I lived here before COVID, after COVID, two different, very different Miami's. Some things for the better, some things for the worse. Obviously, cost of living is terrible now,
Yeah.
but I think it's the price worth paying because it's just a great place. When you can wake up and see the sun every day, it absolutely changes your mental health. And I truly believe that, being able to see the water every day, being able to have the sun every day, it really improves your overall happiness. I don't have to check the weather to see if I need to wear a coat. I can pretty much wear shorts every day. And for that, I'm always grateful.
Yeah, actually being able to see the water definitely increases endorphins. It lowers your blood pressure. It lowers your heart rate. Those are physiological responses for living on the water, which is probably why I do it as well. I'm always happy, and then my wife and I, when we wake up in the morning, some days you've had a tough day the day before, and you're gonna have a tough day that day, and you look in your backyard, and I'm like, I can't complain about anything. We are so blessed to be able to live in such an incredible city that's really turned into an international city while we've been living here. I got here in 2019, went through COVID, and you're absolutely right. It's transformed into a city that is just, it's where people want to come live, do business. Everyone's moving down here. And it's not just, in the United States, I'm talking about across the world. It really has turned into an international city. And a few of my friends who are directly responsible for that. And I talk about them in a couple of different podcasts, but just love being a part of it. How much Spanish have you picked up?
So I took Spanish in high school. And then when I did my residency at U Miami and Jackson, my Spanish was really good. I could actually have a pretty good conversation in Spanish. That 1 year in Chicago, not using it, I lost a significant amount. And then I was working in Memorial and Broward for 3 years. It was a less Spanish speaking population in Broward. Actually, it was only about 20%, whereas, it was like 60% in Miami proper. Now that I'm a Baptist, again, I'm using a lot more of my Spanish. It's coming back. So, I can have, I understand a lot in Spanish. It's more difficult for me to speak it fluidly, but I still use translators for that reason alone, because it's obviously important to have very clear communication. But it's coming back to me. I think I can speak, I can get around. I was in Colombia last year. I could get around Colombia, no problem. Like, I was in Medellin. I can do it. But I still need to do better. I need to get back into like the Rosetta Stone, Duolingo. How's yours?
Espectacular. Imagínate, yo me casé con una dominicana, tuve que aprender y aquí cuando yo fui el jefe de médicos aquí con León, I mean,
Oh,
they had me
okay.
on, they had me on
Yeah.
TV all the time. They were like, wait a second, Indian doctor that speaks Spanish. That was almost like an anomaly, so it worked out really well. And then 70% of Miamians speak Spanish.
Oh, yeah.
There's also a huge stigma in that population about men's health and not talking about it. So that's something that I think, we need to make sure that we're reaching that population in our house, right? In our backyard, basically, right? So learning that, I think, is going to be huge for men's health. I have a requirement for my clinic directors that they should at least be able to converse with those patients that come in, so we can reach that entire population out there.
That's important. You're motivating me. I got to get back in. I got to start just doing more Spanish.
The
Right?
easiest way to do it, get yourself a Latina girlfriend.
I've had them in the past. My Spanish didn't get better.
No, I married a Latina and I had to, because I was like, is she yelling at me or? I have had so much fun doing this. I normally schedule only half an hour because I know how busy you guys are, but I literally think that I could go on the rest of the day just having discussions with you. You are brilliant, bring so much insight to this. And honestly, it's been an absolute honor. Thank you for doing this on such short notice on Saturday morning with us. I appreciate you so much, brother.
No, I'm always willing to make time for you, man. This is great. I had a lot of fun. And yeah, I mean, we didn't even we hit probably like 30% of the things we wanted to talk about, which is great. So have me back on. We'll keep going.
Absolutely.